My name is Lauren Vickery, and my project is on post-traumatic amnesia. In this presentation, I will discuss the different factors that play into post-traumatic amnesia. I will give an overview of memory, the neuroanatomy of memory, and traumatic brain injuries. Then I will discuss topics of post-traumatic amnesia, including its symptoms, types, assessment tools, and recovery and treatment. This presentation will conclude with an article review. One of the brain's main functions is to store information, whether it be learned information, past events, or how to walk, that we can call upon to use again. This stored information is called memory. The first process is called encoding, and it includes the process in which information enters the memory system. Stimuli from the senses are converted into neural activity in the brain that either goes to a memory center or is lost. We then store the information for possible recollection in the future, and then we will retrieve the information that is encoded and stored in memory. There are 4 different types of memory that are classified according to their length of storage and type of information stored. Sensory memory is an automatic memory that results from our perceptions, such as the visual and auditory perceptual systems. Short-term memory lasts anywhere from several seconds to a few minutes. An example would be repeating a list of items that has just been read to you in their original order. Working memory is also a temporary memory state. It is used to perform cognitive processes on the items that are temporarily stored in it, and is used in a process that would require reasoning. It would be like reading back the list that was given to you, but in backwards order. Long-term memory has 2 subsections. Declarative, or explicit memory, refers to the memories that could be consciously recalled. Semantic memory involves pieces of information, such as facts, dates, names, or information we've learned in class. Episodic memory allows you to remember events that you've personally experienced at a specific time and place. This type of memory is most commonly affected by various forms of amnesia. Non-declarative, or implicit memory, is memory retrieved without consciousness. This includes learned behaviors and procedural memory, which is how you do things, like walking. Of the subcortical structures, the hippocampus is the most well-known structure to have associations with memory. It is used for transferring memories from short to long term, also known as consolidation. It also encodes or forms memories. Damage to this structure is known to cause anterograde amnesia. The amygdala, located right above the hippocampus, plays a primary role in emotional learning and memory and enhancing emotional memories into long-term memory. The basal ganglia, particularly in the striatum, which is important in the formation and retrieval of procedural memory. The cerebellum is used in the processing of procedural memories. Frontal lobe is important in working memory and prospective memory, or what we need to do in the future. The prefrontal cortex enables you to keep information available that you need for current reasoning processes. It also helps in processing short-term memories and retaining longer-term memories that aren't task-based. And finally, the temporal lobe is closely associated with autobiographical memory, recognition memory. A traumatic brain injury, or a TBI, is an alteration in brain function or other evidence of brain pathology caused by an external force. This can cause changes in memory, levels of consciousness, confusion, disorientation, or other measurable changes, either perceptual or visual, such as being seen in a brain scan. It can be caused by a closed head injury, such as a fall or a car accident, an open head injury, which penetrates the skull and the brain, or by a diffuse axonal injury, which is caused by the different parts of the brain moving around at different speeds, which causes the delicate neuronal axons to stretch and tear, causing neuronal death. When the brain is injured, it swells. Although many may think that only the location where the brain hits the skull is the only part that is damaged in a traumatic brain injury, all areas of the brain can be affected. In Coop contra Coop injuries, the brain is injured at the point where the brain hits the skull and at the point where it bounces back on the opposite side of the skull. The deep interior of the brain can also be damaged due to the pressure from swelling of other areas. Severities of traumatic brain injuries are classified according to the length of post-traumatic amnesia, duration of the loss of consciousness, severity of confusion, and the nature of the injury. Post-traumatic amnesia is the period of disorientation or confusion following a traumatic brain injury in which a person's memory is affected. After regaining consciousness following a traumatic brain injury, the brain takes some time to become fully conscious again. This recovery period can last for a few minutes, hours, days, or even weeks. It can affect the person's recall of events that have taken place before or after the injury, their own identity, and/or sense of place and time. The amnesia can be retrograde, which affects past memories, or anterograde, which affects the formation of new memories. Amnesia can range from a specific deficit in memory, such as isolated visual recall, to a more severe global impairment that can affect new and old memories. They may ask questions several times, be unable to recognize the people they've met the day before, be unaware of where they are, what day it is, and oftentimes they don't have any recollection of the injury that caused the amnesia. In addition to deficits in memory, there are behavioral changes that are common with patients with post-traumatic amnesia. It can be very frightening for someone to experience PTA, but because PTA is caused by traumatic brain injury, each patient will be different in terms of cognitive, behavioral, or communicative changes that result. These are the cognitive and behavioral changes that are associated with PTA. A confused state is very highly prevalent in PTA patients. It could even be said that the disappearance of confusion often indicates the termination of PTA. Similar to acute delirium or acute traumatic psychosis, the patient experiences spatial and temporal disorientation, such as not knowing where they are or what time or day it is, and also in the synthesis of their perceptions. Psychomotor restlessness, emotional lability, impulsiveness, forgetfulness, anxiety, verbal and physical aggression, and impaired insight are also examples of behavioral changes. As far as executive functioning goes, planning, initiation, self-monitoring, purposeful action, and inhibition are among the possible areas of impairment with PTA. Reaction time, visual, recognition, and information processing speed can also be impaired. As stated earlier, anterograde amnesia is the inability to recognize new information or events presented to them since the onset of amnesia or learning, as well as increased rate of forgetting. So we can see that there are deficits in the encoding, storage, and retrieval of the memories. They may ask questions several times, forget to turn off things, misplace objects, or forget appointments, for example. Their memories for things or events prior to the onset of amnesia may be unimpaired. Short-term memory allows the person to temporarily maintain information, but the information is lost upon distraction. It is usually associated with damage to the hippocampus or other areas that work in the formation of new memories, such as the temporal lobe. However, when presented with an object several times, it has been shown that they begin to feel like they've seen the object before, but they couldn't be able to tell you when they've seen the object. Forming new habits, acquiring perceptual or motor skills, such as learning how to play golf or reading text in the reflection of a mirror, are also possible skills that are able to be learned, even with anterograde amnesia. Retrograde amnesia is the inability to remember or recognize information or events that occurred prior to the onset of amnesia and is initially less debilitating than anterograde amnesia. So, this type of amnesia is impairments in the storage or retrieval process of the memory. Typically, memories that are closer to the time of onset of amnesia are more impaired than more remote memories from, say, a decade ago. Although in cases with more severe or extensive brain damage, this probably won't apply to them. Retrograde amnesia is associated with hippocampal damage and related structures as well. It has been thought that it causes retrograde amnesia due to the impairing in the consolidation process of memory. This process begins in the hippocampus, where memories first grow, and then is gradually transferred to other brain structures for greater long-term storage. This would explain why more recent past memories are affected by this type of amnesia, because older memories have already been fully consolidated. Global amnesia is usually associated with severe brain injuries and involves deficits in all areas of memory, past and present. Studies have shown that the duration and severity of post-traumatic amnesia directly correlates to the patient's rating on the Glasgow Coma Scale and their length of hospital stay. And here we have a table depicting the generally accepted guidelines of PTA, duration, and its link to severity of brain injury. Less than 24 hours of PTA usually indicates a mild to moderate TBI, while there have been cases of PTA lasting for months with extremely severe TBIs. Although speech, voice, and language disorders can arise from a traumatic brain injury and coexist with post-traumatic amnesia, such as aphasia, apraxia, or dysarthria, there are some aspects of communication that can be directly affected due to PTA. Attention can be affected due to memory impairment and interfere with the continuation of conversation between the patient and their communicative partner. Memory, the prime deficit in PTA, can impact the patient's ability to retain information that is being spoken to them, and this also directly affects their ability to repeat information. If presented with a topic, introduced to a new object, or asked to recall something from the past, it would also impact their use of language. And finally, if the patient has spatial perception deficits, they may have pragmatic deficits in terms of how to speak to professionals versus their family members and conversational turn-taking in those situations. Because it is typical for the person with post-traumatic amnesia to be generally disoriented and confused, it is important to frequently reassure them of a few things. In the case they have visual recognition deficits, identifying yourself when you come in the room can help the person feel more comfortable. Let them know that they've had an injury, they're safe in the hospital, and that things will be okay. Let them know the time and date in case of a temporal impairment. If the person is struggling with retrograde amnesia, talk to them about their pre-injury while they recover to help in their identification process. Talk about their hobbies, job, family and friends, or other important things in their life. It is also important to remember not to ask them questions such as, "Do you remember the time we went to Washington?" For it's better to say something like, "I really enjoyed the trip to Washington we took last year." Finally, being understanding throughout the recovery process is extremely important. They may say things they would never say before the injury. A brain injury and PTA can temporarily alter how they handle and respond to situations. So it's important to not take anything personally if they say something hurtful. Being patient during the process is the most helpful thing that you can do. The speech-language pathologist plays an important part in an interdisciplinary team that works to assess and treat various deficits that present itself in a traumatic brain injury and post-traumatic amnesia. The speech-language pathologist may also administer the PTA assessment themselves. Although many times they won't do a formal assessment of speech or language when a patient has PTA, sometimes they do informal assessments of speech or language to determine quickly if there's an obvious impairment that needs to be addressed. This also goes for swallowing. Because dysphagia, or disordered swallowing, can be life-threatening if left unnoticed, they will probably do a quick clinical swallow evaluation after the injury and after they wake up. SLPs also specialize in cognitive tasks, so the patient may be working directly with the SLP in regaining cognitive functioning and learning strategies for relearning their memory. Finally, the SLP is a great resource for concerned families about their loved ones during this time. The SLP will talk them through the process and answer any questions about communication, swallowing, and memory or cognitive functioning in their loved one with PTA. The assessments also give the professionals a tool to help measure the duration and prognosis of the patient's post-traumatic amnesia. The assessment allows the professionals to make decisions concerning the patient's well-being during their hospital stay, such as their ability to make decisions for themselves, whether or not they need constant supervision, referrals for a rehabilitation specialist, clues to their cognitive abilities and deficits following the TBI, and a prognosis for their level of functioning after discharge in comparison to how they were before the brain injury. There are several psychometric tests that are available to assess post-traumatic amnesia. The GOAT test, or Galveston Orientation and Amnesia Test, assesses PTA in patients who've had severe TBIs. There are 10 questions on person, place, time, and memory recall that evaluate spatial and temporal orientation and is scored out of 100 points. There are also modified versions. MOTE, being for patients with expressive language deficits and includes multiple choice, and COAT, which is used for children. The Westmead PTA scale is used for patients with moderate to severe TBIs. It consists of 12 questions that evaluates orientation, person, place, time, and the ability to consistently retain information from one day to another. The test is administered every day until they get a perfect score for 3 consecutive days. Also, informal assessments can be used just by talking to them, seeing if they remember your name, your face, where they are, and these quick assessments can kind of give you an idea of how they are in terms of memory impairments. Because PTA is often a temporary state, sometimes the brain just needs time to fully recover and wake up after a brain injury. It's kind of like how we sleep at night to restore our mind and body. After an injury, certain parts of the brain need to go under extended recovery or sleep time in order to bring those levels of functioning back. During that time, neurons, or the cells in your brain, are repairing themselves. Neuroplasticity also allows our brain to reroute pathways in the case of extensive damage, so it assigns certain functions to other areas of the brain if needed. As mentioned, PTA usually resolves over time. However, in the case of very severe injuries, there may be long-term damage that may never be fully recovered. Until then, family support is crucial in reestablishing the person back into daily life. Therapists can work with patients on skills and strategies that can be used to help consolidate memory deficits. Compensatory strategies, such as writing every little thing down in a daily planner, have been proven to be extremely helpful in patients with anterograde amnesia. And again, the longer the PTA, the longer the time until full recovery can be made. For my article review, I chose the article titled Speech Pathologist's Current Practice with Cognitive Communication Assessment During Post-Traumatic Amnesia, a survey. There is a lack of specific guidelines for assessing cognitive communication impairments in patients with PTA. There are resources available for SLPs on assessment after TBI in general, but those guidelines may not be appropriate for those with PTA. There is, however, literature from related fields such as psychology, neurology, PT, and OT, with evaluation and management information for PTA impairments. A survey was conducted across current SLPs to investigate their current practice with PTA patients. The results included most, 78%, of SLPs reporting using informal screening or assessments and observations when the patients had PTA, and conducting formal assessments after the disappearance of PTA. 19% of respondents reported using no assessment during PTA. Although it was generally accepted that formal tests were not appropriate for patients that still had PTA, some reported that they had used published, standardized tests on occasion for specific purposes. In conclusion, it appears that SLPs rely on their clinical experience and knowledge when making judgments about cognitive communication impairments in PTA patients.